For comprehensive exams, I'm going to give you two examples. Both of these are situations where you're seeing the patient for a comprehensive, so the goal is to get a 92014 code efficiently. This first one's going to be as if it's just managed care, your good old VSP, no medical diagnosis, or maybe just ancillary medical diagnoses. I'm setting this up as if the tech is already doing your chief complaint. They're checking vision. They're adding that information in for you. So these are just the steps you can take for a comprehensive exam prior to even going in with the patient so that your CPT codes are ready to go. Two ways of going about this. If you've seen the patient already in Eyefinity, you can go ahead and click the View Import Previous button, and you can go ahead and select anything that applies. This helps you pull forward like your CD ratios, your exam findings here with this eye exam click. And then you can pull any diagnoses forward also. If there are any plans like a prescription or anything like that that you don't want in there, so maybe they're not getting their contact lens assessment this year, you can uncheck anything. You can also go into other exams and keep adding information, and it will pull all of that forward in addition to the first check marks that you made, which is pretty cool. You'd then hit apply, and all of that's going to pull in. As long as everything was correct last year, you're going to go ahead and get your 92014. If this is maybe a new patient or you haven't yet seen them in Eyefinity, then you're going to use the good old protocol way. And again, I do this before going in with the patient so that I don't have to spend time clicking through the exam while I'm trying to talk to my patient. I'll take a peek. This one doesn't have it in here because it's not a real patient, but the tech they'll either pull forward their last manifest, they're going to do lensometry, they're going to do an autorefraction, one of those things. So you're going to get a sense of what their base refractive diagnosis is going to be. You're going to go into protocols. You're going to go ahead and set your correct exam findings to normal. You'll do your retinal screening, and then you'll pick the most appropriate refractive diagnosis. 3 clicks for most patients, very easy. And as long as this vision summary is green, you're going to already, let's scroll down here with this test patient. You're going to have your 92014 with correct diagnosis codes before you even step foot in with the patient. All you have to do then with the patient is do a refraction, prescribe some contacts, make sure they're finalized. You can send over your exam findings and your glasses, and you're good to go. You can then go in after the fact and add in any extra information. You might add your CD ratios after the fact. All of that is fine to add after you're done with the patient, and it's just going to improve your efficiency in getting those correct charges over to your opticians. Keep in mind to keep this vision summary green. I'll click into this here. You're just going to want to make sure everything is completed that has an asterisk next to it. So acuities, IOP, pupils, motility, visual fields. Anything with a little star, that's what's required to be able to get a 92014. If there's something that you're attempting and you're not able to achieve, maybe your patient's nonverbal or they're squinting too much with the pressures, you'll want to put a note in there that you're unable to get those numbers. Let me get over to pressures, for example. Attempted but not achieved is going to also let you maintain that 92014. If you leave it blank, you're not going to get a 92014. The other scenario is going to be a medical visit where we want that primary diagnosis to be medical, and so we want to be efficient in that. I'll pull up this example here. And delete out everything that I had. So if it's a comprehensive exam, but the patient is needing to be billed for their medical visit, you're going to go into the ocular exam to start, and then you're going to go ahead and click whichever diagnosis you want to have as your primary diagnosis. The only time this doesn't work great is in a new patient where you're going in and talking to them, but again, you can take a peek into the a chief complaint. Maybe they're talking about dry eye. Maybe you notice in the case history they have a history of glaucoma, or when you're in with the patient, you can go ahead and do these clicks too. You don't have to get everything in from the beginning. You can start simple, get your CPT codes, and then add the rest later. So maybe this patient has cataracts. We'll go ahead and add the age-related cataract. You do want to follow your ICD-10 expert. We're going to give them combined cataracts in both eyes. And I'm going to keep it simple. I'm just going to do some counseling. Anything that goes to medical does need to have a little bit of a personal touch. Otherwise, it can be a little sketchy on an audit. Pre-surgical, basically anything that doesn't just say monitor or observe. We want it to have a little bit of a conversation there. So pre-surgical, no reduced VA. Anything like that that might be appropriate for that patient. And again, you can add those little notes in after the fact. Just having that counseling block in is all you need to start. We're going to hit done, and then we're going to go ahead and add in our protocols. That way we just don't have to reorder. You can always reorder if you need to, but if you do your protocols first, you'll definitely need to reorder. Do remember that anybody that is Medicare age either has to have dilated, declined, or deferred dilation clicked, and so that's why I have these little cheaters here. Everything that says Medicare. Even if this is going to VSP, if the patient is 65 or older, go ahead and get in the habit of clicking one of these Medicare boxes instead of the regular exam findings normal. Just like the other exam, I'm going to go ahead and do my Optos, and then we'll pick the most appropriate refractive diagnosis. We'll hit apply. And you can see before we've even gone in with the patient, because my tech has done their pre-testing, my 92004 code is already popping up. You can send those charges over, you can do your refractions, do everything like that while you're in with the patient. And then when you're done, you can go in and add all of your ancillary exam findings. You're going to want exam findings in here that supports that cataract diagnosis so that we can justify actually billing it to medical. We're going to do our CD ratios, and all of this can be done after the fact. Maybe if the patient is dilating, you can add it in then, but none of it is mandatory to get the codes to populate. It's just mandatory for you to have a complete chart. You can go back into any diagnoses, add more information if you would like. And this can all be done after the fact. Again, the simple stuff is what gets you to your 92004 codes.